I'm Dr. Suranta. Now, few minutes past 7 o'clock. Can we start now?
I'm ready, Dr. Suranta.
Yeah, thank you very much. And please give me one or 2 minutes to introduce you. And
Sure.
I'm Dr. Suranta Perera, Vice President of Sri Lanka Medical Association. And we are privileged and honored to have Senior Professor Sam Kularatne for joining us to deliver today's lecture on management of snake bites. And he's a Senior Professor of Medicine at the Department of Medicine, Faculty of Medicine at University of Peradeniya. And not only that, he, with Dr. Malik and with the other crowd in our snake bite committee, Professor Sam Kularatne did a very played an important role in establishing guidelines and then developing relevant documents. And he has vast experience in this subject. I think all the undergraduates who are joining today are privileged and to listen to his lecture. This will be more clinically oriented to make sure that you will be benefited. And at the end of the lecture, you may post your question at the chat box. This question will be answered. So thank you very much. And please commence the lecture.
Good evening. Thank you very much, Dr. Suranta Perera, for your kind words of introduction and for the invitation to deliver this lecture. The target audience is students, medical students, mainly. So I think it's a special privilege for me to meet medical students from all over the country. Otherwise, I'm very much confined to Peradeniya. So once again, thank for the SLMA program of Saturday Talks. So the topic is management of snake bite. I would be actually discussing a number of case scenarios, and this discussion will be based on these case scenarios with the intention that the students will understand the subject as well as they will understand the importance of it and remember and would be able to apply in future in the management of snake bite. Let me actually again stop share and again restart because right, okay. So this is my first case scenario. A 15-year-old girl developed abdominal pain while sleeping on a mat on floor. In the early morning, her vision was impaired and could not get up. A snake was found inside the compound. What is the offending snake? So please read the scenario yourself and try to answer this question. What is the offending snake? Because of the interest of time, I will be moving a bit fast. Here you are given a list of offending snakes: common crate, Russell's viper, cobra, hump-nosed viper, saw-scale viper. So if you have actually is decided on the offending snake, then next question is, on admission to the hospital, what is the immediate management? Okay, right. So we'll move on. So this is the offending snake, common crate, right? Common crate. So this is called Mangamarua, Telkaravala, Habara, by people. So it's a common crate. So this is the distribution of a common crate in the island. It is mainly in the dry zone. And the poor people who are sleeping on the floor of this type of compounds are bitten at night. So that is the typical scenario of common crate bite. So this is a news paper article of a common crate bite. The commonest symptom is the victim gets abdominal pain. Occasionally, because of the abdominal pain, patient might end up in surgical wards. That's also happened. By the time patient develop the abdominal pain, and with time, patient develop the neuromuscular paralysis. So similar to common crate, this is a Ceylon crate. Both are crates, but Ceylon crate is very much confined to wet zone. Most of the bites are rare. I am not going to discuss about the morphology because I expect students to read about the morphology and identification of snakes by yourself. The Ceylon crate also has the same characteristics, means they enter the houses at night and bite the victims and develop the same scenario of abdominal pain and gradual neuromuscular paralysis. So this is what happened. The patient has neuromuscular paralysis with complete ptosis, unable to open the mouth, and another patient who is being ventilated because of the respiratory paralysis. So what is the immediate management? Immediate management is resuscitation, because by the time patient comes to the hospital, patient may be in a grave condition where respiration is failing and may be at the verge of arrest. So resuscitation is life-saving. So emergency trolley and the ambu bag must be ready for resuscitation. The next scenario, a 35-year-old farmer was bitten by a snake while reaping paddy. That's harvesting paddy. In the hospital, he had external ophthalmoplegia and incoagulable blood. The offending snake was not available. Again, what is the probable offending snake? The same list. Common crate, Russell's viper, cobra, hump-nosed viper, saw-scale viper. Then, is there a specific treatment for envenoming? So the next question I am asking, what is the treatment for envenoming? So definitely common crate is out, because already we have discussed. Then out of other four, you should be able to think about the offending snake. Hope you have figured about this offending snake. This is a Russell's viper. Russell's viper. This offending snake is Russell's viper. The Russell's viper, I am sure you would have seen. Easy to recognize. It is widely distributed in everywhere you see Russell's viper. Even in cities, they are found. I have read newspapers of finding Russell's vipers in the middle of Colombo, right? In the gutters. So they can be anywhere in the island. But if you take the rural communities, most of the victims are farmers. During the paddy cultivation, during the daytime, the farmers are bitten. But it is a nocturnal species. It move during the night and look for prey. But the daytime, they are hiding and sleeping or hibernating in the paddy fields because of the cold, the water and the cold environment. So this type of paddy harvesting, where you use the manual harvesting with a sickle, is not the practice now. But this rare photograph, you might see the typical way of reaping paddy 2 decades ago. Now, that is replaced by these machines. I'm sure you would have seen or may not have seen. These are the harvesting machines. The people call it boothia. I don't know if they have heard about it, but still, paddy field is still a common place of Russell's viper bite, because people have to come to paddy field, and commonly Russell's vipers are found. What are the clinical manifestations? As I have given in the scenario, the commonest is the coagulopathy, incoagulable blood. Also produce neuropathy, neurotoxicity, where neuromuscular paralysis occur. So in this picture, you see the patient has complete ptosis. So compared to common grade bite, here the respiratory paralysis is extremely rare. It is commonly the ocular muscle paralysis you see in Russell's viper bite, or to some extent facial muscles, not the respiratory muscles. So here you see the incoagulable blood in this picture. So the specific treatment is antivenom. I will talk to you as antivenom in detail to the latter part of this lecture. The specific treatment is antivenom that is available in Sri Lanka. That's a polyvalent antivenom imported from India. My third case scenario, the 35-year-old housewife was bitten by a snake on her left thumb while she was arranging flower pots in the garden. She developed severe pain and hemorrhagic blister at the site of bite. In the hospital, she was managed with therapeutic plasma exchange and dialysis. What is the offending snake? Same list is given again. Right? You can think about what is the offending snake based on the clinical scenario. Right? And the next question is, what are the complications? What are the complications the patient has developed? What are the complications has she developed? So think about the identification of the offending snake from the case scenario and the possible complications. So this is the offending snake. This is hump-nose viper. Hump-nose viper. Hypnale. So hump-nose vipers, viper bites are the commonest snake bite in Sri Lanka. That is, out of all the venomous snakes, is the commonest. And these hump-nose are found all over Sri Lanka except northern part. We don't see hump-nose viper bites or hump-nose habitats in northern part because it prefers much cooler environment where it stays under flower pots, under leaf litters, right? All kinds of heaps of things that they are found, especially in the estates and so on. So this, for example, that particular scenario, it is very often the ladies, housewives, they meddle with these flower pots. And without their knowledge, they get the hump-nose vipers because they are hiding somewhere here underneath. So that is very essential that doctors should educate the public when they're handling with hands these flower pots and so on. They have to be careful. So this particular patient had the bite on the thumb, but there's no blister here. And coming to the complications, this is the dreaded complication the patient could have. Compared to Russell's viper bite, coagulopathy is less common in hump-nose viper bite. Maybe less than 10% of the patients after hump-nose viper bite, patient develop coagulopathy. Otherwise, 90% of the hump nose bite, it was just the local swelling and the blister formation. Coagulopathy is just the increased coagulation of blood, clotting time of the blood, and that get corrected itself with time. Occasionally, the complication that patient might develop acute renal failure. So this particular patient who had hump nose bite has developed severe glomerular necrosis, right? After hump nose bite. In fact, this patient died because 90% of the glomeruli are necrosed. So another complication that could occur commonly in hump nose bite is thrombotic microangiopathy. There are three conditions occurring in thrombotic microangiopathy. That is MAHA, microangiopathic hemolytic anemia, acute renal failure, and thrombocytopenia. So when this thrombotic microangiopathy develops, the patient needs dialysis and therapeutic plasma exchange. But even this therapeutic plasma exchange, though there are some debates, but that is the option available. So in hump nose bite, the patient could die due to acute renal damage. Next scenario, a 17-year-old girl was bitten by a snake on her right leg above the ankle when she went to have a bath from a village tank at about 11 a.m. That is daytime. So this girl has gone to village tank to have a bath during daytime. Snake was not identified, and she was admitted to local hospital with swelling and discoloration of the bitten area. In 3 hours, swelling spread to knee level with tense calf and necrosis of skin. So with a long scenario, young girl bitten by a snake in the right leg above the ankle, a little bit higher in the leg, in the village tank, and then there's a skin discoloration, and that is spreading up to knee level. So identify the offending snake. Same list is coming. And my question is, what is the most appropriate management? Maybe some of you have already thought about a snake. We'll move on. So this is a snake. I'm sure you would have seen cobra. If you haven't seen a cobra, it is rather unusual. Similar to Russell's vipers, cobra, they are found everywhere in the island, distributed all over the island. Cobra is found everywhere, even in the major cities. The dreaded two complications. One is the severe local necrosis. You see, this patient had necrosis, and surgically the necrotic parts have been disrupted. Also, patient can develop rapid neuromuscular paralysis leading to respiratory paralysis. So after cobra bite, similar to crate bite, before patient reach to the hospital, they can die because of the neuromuscular paralysis and respiratory paralysis. This is a beautiful picture of a village tank. If you have gone to dry zone, Rajarata, Anuradhapura, you will find this type of beautiful tanks all over scattered. So that's about the cobra bite. So the immediate management is the management of the local necrosis. So what is recommended is the patient should be referred to the surgeon or surgical casualties, and early intervention is necessary. As in this case scenario, the patient had tensed calf. That means that is compartmental syndrome. That compartment should be relieved. Here is not shown, but when the whole leg is swollen, that is compartmental syndrome. Sometimes the bite has happened in the arm, whole arm get swollen, and the fingers might get gangrene because of the tense compartment in the forearm. So where decompression is necessary. So surgical intervention is the immediate management. Next case scenario. A 35-year-old army soldier was bitten by a snake in the beach of Jaffna at the dusk. The killed snake specimen was brought to the hospital along with the patient. Again, identify the offending snake. The same list is given. So the key points are army soldier. The bite has happened in Jaffna, late evening, and the snake was killed and brought. Does he need antivenom therapy? So that decision is based on the identification of the snake. So I'm sure that you would have thought about what is the commonest snake bite in northern part of the island in the sandy beaches. So this is that snake, saw-scale viper. You should be able to identify saw-scale viper. That is not bigger as Rhesus viper, but is the same size as hump-nose viper. Maybe just 1 foot to 2 feet. The identification feature is you see this dragger mark on the head. Very vicious snake. And so it has the hissing sound when it get excited. It coils rub each other and produces some kind of a scary hissing sound. So this is the place. They are there. In the evening, these snakes come to the sand and they dart at the person and bite, right? So they may be hiding under this greenery. So this is a distribution of the saw-scale viper. You see along the coastal beach from Putlam, then in Jaffna, again it comes down to Yal. This is the distribution based on the finding of specimen in Sri Lanka. So coming to the treatment, again, the Indian polyvalent antivenom is the treatment. And so far, there are no deaths due to saw-scale viper bite in Sri Lanka, but still is considered deadly snakes because with the antivenom, they recover. Next scenario, the 55-year-old estate worker was bitten by a snake on the right hand while plucking teeth. So 3 questions are there. Identify the offending snake. What are the clinical manifestations? What is the specific treatment does she need? So this has happened in a T state, right? So you need to know the daytime a snake in the upcountry T state, and that snake is among the tea leaves camouflaged. So this is a snake. This is a green pit viper. It's a green pit viper, very beautiful snake. Purposefully, actually, I am avoiding the taxonomic names of these snakes because you can actually read about their taxonomic name. That names are very important. For example, this snake is called Trimerosus trigonocephalus, but this, again, it has 3 eyes. So please learn the taxonomic names of all these snakes I have so far discussed. If I try to discuss all those things, it will take a long time to finish the lecture. So this is the distribution of green pit viper in the island. Mainly is wet zone but you find even green pit vipers in the dry zone in Anuradhapura. So it is not a deadly snake, but what happens is it causes severe local swelling. I had one patient, in fact, he's a snake handler who was bitten by a green pit viper on the palm. And again, it led to severe local swelling and the compartmental syndrome. And he need to actually slit the forearm, both anterior and posterior, to relieve it, ending up with some kind of disability. So that's what can happen with the green pit viper. Next scenario. The 35-year-old fisherman had a prick injury to his right foot when while fishing in an estuary. Estuary is the river mouth, which is actually meet in the sea. So this is a fisherman who was fishing at the river mouth and where he had a prick injury. Later, he developed severe body pains and passed dark-colored urine. So my questions are, what is the cause of prick injury? What is the reason for body pain? Why is the urine color dark? So please think about this prick injury, right? So there are so many things can prick the foot in the water at estuary. Okay, but here the prick follows by body pain and passing dark-colored urine. So this is a patient, it's a true patient, one of my patients, right? So this patient is in a severe body pain. Even he was not able to open the mouth. It's like tetanus. Call it pseudotetanus. And this is the urine he passed, very dark brown urine. So this is the ophionic snake. These are sea snakes. So these are two kinds of species of sea snakes. You can identify the sea snake by the tail. So the tail is actually flat, right? It's like a paddle, right? It's a flat because for the swimming, the tail has adopted for swimming purpose, right? So sea snakes are found right around the island, right? Right around the island. But the sea snake bites are extremely rare. And I have the opportunity to see plenty of sea snake when I visited Jaffna in Kankasanture in the early morning. The boats, fishing boats coming to the shore, always have entrapped sea snakes in their nets. So about hundreds of sea snakes are thrown back to the sea early in the morning. But most of they are dead by that time. This is my last case scenario. I think I really meant for the young doctors this case scenario with highlighting importance about snake bite. The post-intern medical officer from Colombo, in his first appointment to Kotavihara PU in the northwestern province, is called to manage a patient after Russell's viper bite at 8 p.m. He decided to treat the patient with antivenom. He has no previous experience of managing snake bites. However, he has in his possession a book on management of snake bite. And while he is reading the text, these are the doubts arose in his mind. So this is what really happening. During the internship, after the final exam, you will do your internship in cities and may not see snake bites at all during the whole appointment. But you are posted to a peripheral unit in a dry zone. There you are challenged to manage snake bite. Right? So that is the reason behind of this scenario I have decided. So these are the doubts about arose in this doctor's mind about this whole situation of management of the patient. Though there are books, there's a power failure. Yeah, there's a power failure. I'm sure you can see me, right? Right. Can you all hear me, please? Can you all hear me?
Yes, sir. We can hear you.
Okay. Okay, that's fine. So these are the questions. Are there indications to give antivenom to the patient? How to prevent reactions to antivenom with pre-medications? How to manage anaphylaxis during antivenom infusion? How to set up antivenom infusion? So these common queries the young doctor might have. Are there indications to give antivenom? Right? Knowing that reactions can occur, should be given pre-medications, or if a reaction develops, how to manage anaphylaxis. Also, or to set up an antivenom infusion. So where to find the answers? So these are the resources available. Here you see 1983 publication. These are two publications I have done myself. And this is the guideline which is published in 2011. But you are lucky, today you have the latest guideline. So please go to SLMA website and you go to publication, and on the top you will see the SLMA guideline for management of snake bite 2022. That is the latest guideline available of all, I think, all SLMA publications, right? So guideline development of snake bite has been going on for last 2 decades or 2 to 3 decades, and we have done the latest guideline by 2021, and now 22 it is available. So if you go to the guideline, you will see the pictures of the snakes and their identification key. For example, if you see common crate, you see these large hexagonal scales, right? And then management of snake bite. So over the next few minutes, I will go through management of snake bite quickly. So first thing, the epidemiology and clinical manifestations, then to know something about the venom, then the clinical management, also feeding guideline. There are plenty of snakes in Sri Lanka. I mean, we need to cohabitate with snakes. Nobody should kill snake. They should be conserved, right? Even though there are so many snake species, only few are medically important. If you come to a snake bite admissions, before 1980s, people did not come to hospital, but after 1980, the hospital admissions increase and the deaths also gradually decline. But still, some patients die after snake bite, so it is difficult to achieve zero death rate. You will understand the reasons. So it is imperative that people should avoid snake bites, because snake bite is a potentially fatal situation. I have gone through all the venomous snakes and the medical import snakes so far. Russell's viper, Dabea russeli, common crate, Bungarus ceruleus, cobra, Naya. This is not Naja, Naya. Hump nose, there are 3 species, Hypnale, Hypnale nepa, Hypnale sara, Source-scale viper, Echis carinatus, Ceylon crest, Bungarus ceruleus, green pit viper, Trimeresus trigonocephalus. There are so many sea snakes. Out of this, Enhydrina schistosa, this is the most dangerous sea snake, that is called Valacaria. So the snake has this venom apparatus, venom gland, and they inject venom through this canalized fangs. So coming to the venom is 90% protein. is a complex mixture of low molecular weight peptides. Also has enzymes, proteases, phospholipid A2, esterases, hyaluronidases, nucleotidases, lithinases, procoagulant, zinc metalloproteinases, hemorrhagins, biological active amine, serotonin. So actually snake venom is a soup, right? It has so many proteins and enzymes. So when you're actually developing antivenom, the antivenom should cover all these proteins and enzymes. So that is the challenge. One of the common important, this enzyme is phospholipase A2 because it has multiple effects. So hematotoxins. Hematotoxins mean the toxins affecting the blood. They are procoagulants, hemorrhagins. Then the neurotoxins. They could act neuromuscular junctions, presynaptic or postsynaptic, again phospholipase A2. Then the rhabdomyolysis. Like in sea snake bite, they get rhabdomyolysis. That is due to phospholipase A2. Then the local effects is due to hyaluronidases and proteases. So this is a neuromuscular junction, right? I'm sure you have learned that in physiology. The cobra venoms act on the postsynaptic membrane. Crate venom acts on the presynaptic membrane. These are potential the MCQ questions about the venom of snakes you might come across in your MCQs in final exam. These are clotting cascades. So vipers venom are acting on the clotting cascade. They are procoagulants. More than the anticoagulants, they are procoagulants. So leading to finally what is called venom-induced consumptive coagulopathy. That is called venom-induced consumptive coagulopathy. It is somewhat similar to DIC, disseminated intravascular coagulation, but in snake envenoming, it is called venom-induced consumptive coagulopathy. Then coming to the snake bite management. So management should start at the place of bite, then the local hospital. Most of the time patients go to local hospital. From there, patients are transferred to tertiary care. So management should happen during transfer, otherwise patient might die during the transfer. Then the management at the tertiary care hospital. Please be prepared to manage the patient at all these four places. At the place of the bite, local hospital, during the transfer, tertiary care. So that means patient should not be transferred without attention, right? So the medical officer should accompany with all the resuscitation facilities. Management at the site is the first aid. That is the reassurance, immobilize the patient and take the patient to the nearest hospital immediately. Should not do this type of application of tourniquet because that will damaging more. These improvised tourniquets are not recommended. But the bitten part can have a kind of a splint to immobilize. Then these are the steps of management as patient come to tertiary hospital or local hospital. Initial resuscitation, then the initial assessment. Then should identify the offending snake. Then see the evidence of envenoming. Then if there's envenoming, antivenom is necessary. Then start antivenom, but please anticipate reactions. Then other supportive care and further assessment and look for complications. So the SLMA, we have what is called a snake bite hotline, right? So there are many experts in this hotline. So at any time, any doctor can contact us to get advice about the snake bite management. So it is not necessary to have the killed specimen to identify the snake. So we are not recommending to kill the snake as well, but the killed specimen is available to get down. But otherwise, depending on the different manifestations, you can decide on the offending snake. This is called syndromic diagnosis, right? So I have gone through these things. In case of rustless bite, it's coagulopathy and local effects and some neurotoxicity. Crate, it is pure neurotoxicity, right? Cobra, mainly local effects, right? So like that, if you put the things together, circumstantial evidence and the clinical features, you can recognize the offending snake by syndromic approach. Evidence of envenoming, clinical manifestations, you have to do a laboratory test for the coagulopathy, but lab tests are not necessary. There's a bedside test is called 20-minute whole blood clotting test at bedside. So you have to take a glass tube, put the blood there, and leave it for 20 minutes and see for clotting. But that is the simple words, but this we describe in the guideline. How do you properly bedside test? There also you need to have proper apparatus. Use a clean, dry 5 ml borosilicate glass test tube of internal diameter of 10 millimeter. This is the ideal tube. Collect 1 ml of blood into it. Leave it undisturbed for 20 minutes. If not infallible, detect severe coagulopathy. Right? So it is not necessary to do more advanced tests, but if facilities are available, you can do PTINR and the fibrinogen level as well. But this just because one test is negative, that doesn't mean you can be happy, because envenoming is happening with time. So this test should be repeated in the interval, maybe hourly, maybe 2 hourly. So the clinician should decide how frequently you should do the test until it becomes positive. So once you do this initial part, then you need to actually decide whether there are indications for antivenom therapy. For example, in Russell's five bite, if there's a coagulopathy, by increase whole blood clotting test, and the neurotoxicity, definitely you have to give antivenom. But if the expert is available, if the patient has abdominal pain, proven Russell's viper, with there's a fan marks, still it could be envenoming. Cobra, if there's severe systemic envenoming, yes, antivenom should be given. Also, marked local envenoming. Trait is for the neurotoxicity. Source scale is coagulopathy. So if there are evidence for envenoming, then antivenom need to be given. So this is antivenom. I told you that's a polyspecific antivenom, polyvalent antivenom that covers 4 snakes, because this is manufactured in India. So India, they call what is called Big Four. The Indian Big Four are Cobra, Russell's viper, source scale viper, and the crate, common crate. So they manufacture the antivenom for these Big Four. So we are in the same geographical area, right, in the subcontinent. So the snake, what we find in India, also they are in Sri Lanka. So there's a cross use of this antivenom, right? But not 100%, right? So we need to develop our local antivenom for our Sri Lankan species. But this Indian antivenom does not cover hump-nose viper, green pit, and the sea snake. So it is not to give this antivenom for these snakes, because you will unnecessarily come across reactions. So again, the guideline gives how to give the antivenom dose. So we usually start with 20 vials, but depending on the severity, maybe more, right? Also, this whole blood clotting test is done 6 hourly, and if the coagulopathy is persisting, we have to repeat the antivenom during first 48 hours. Apart from Russell's viper bite, in crates and cobra, we only give the first dose of antivenom. This is antivenom. And the dose I have already said, maybe 10 vials, 20 vials, 30 vials. Then may repeat it. And the infusion time of antivenom is 1 hour. So our guideline gives how to administer the antivenom. Then coming to pre-medications. These are different trials we have done in Sri Lanka, but our guideline, we recommend to give adrenaline subcutaneously if you anticipate antivenom reactions as prophylaxis. 0.25 subcutaneously before antivenom infusion, provided there are no contraindication for adrenaline, right? In pregnancy, it's not recommended at all. But when you're giving antivenom, the dreaded problem is the allergic reactions, right? So these allergic reactions could be pyrogenic, anaphylactic, or anaphylactoid. So management of anaphylaxis is a medical emergency. So we expect medical students to be very familiar with management of anaphylaxis. It is common to all kinds of anaphylaxis. Maybe drug, maybe food, maybe antivenom or serum, whatever. So the management is the same. So please be thorough with management of anaphylaxis. All the steps should be in your fingertips, because no time for you to refer up books. You should be very familiar with the drugs and the doses. So when you talk about the anaphylaxis, you can decide the anaphylaxis with a mild, moderate to severe. Mild is just urticaria. Severe is severe hypotension and bronchospasm. In between, moderate. The mild reaction may propagate to moderate and severe. Very mild reaction, even you can just give chlorpheniramine, even the adrenaline subcutaneously, but some experts, they do not actually say subcutaneously, but in snakebite we have used. But if it is moderate, definitely it is the IM adrenaline, right? Even the mild reactions, you can give IM adrenaline, right? The thing is, when you go adrenaline to somebody is having a normal blood pressure or high blood pressure might shoots up, right? So if the blood pressure is dropping, definitely you need to give IM adrenaline. And the need to repeat every 10 minutes until you get the good response. In children, the dose should be adjusted according to the body weight. When it comes to severe reactions, some patients develop severe stridor or wheezing. In that case, adrenaline can be nebulized apart from giving IM, right? The other supportive care like chlorpheniramine and hydrocortisone can be given at the same time, but our guideline very much do not very much stress on the hydrocortisone and chlorpheniramine on research evidence, but it's still good to give, because if you have to repeat the antivenom later, giving hydrocortisone might prevent the reactions for the second dose of antivenom. So, I mean, this is almost the last slide. I mean, you can read this. This is a kind of advertisement, right? Advertisement for Jack Daniel, right? I hope that once you read it, you will enjoy the fun there, right? Okay, I hope you would have enjoyed the advertisement, right? So I think that's all what I can share with you all, because this is a big topic, and for the interest of time, that's all I intend to share with you. But if you have any questions, I can answer. I see there are so many questions in chat box. Let me see, what are they? They are their answers, right? Yeah, they're answers, right? That you'll have answered some questions, right? Right. Any questions? You can unmute and actually ask me any questions if you have any queries, any student, right? No problem.
It seems that they don't have many questions.
Surant, there are some questions, I saw, right?
Yeah, that's what I think.
Yeah. Let me see. Yes. Is there any adverse effects of giving antivenom before envenomation feature occur? That's a good question, right? Should you give antivenom before evidence of envenoming? We don't recommend, right? You need to wait for envenoming because antivenom reactions are very dangerous. So you may unnecessarily subject the patient to antivenom reactions if you give antivenom before envenoming. So you have to wait until the proper indication appears with envenoming. If somebody develop anaphylaxis to antivenom if somebody develop anaphylaxis to AVS after managing it, do we? Yes, that's also a good question. If somebody develop antivenom reactions, for the management, we stop the antivenom infusion temporarily and manage the antivenom reactions. And when the patient is fully settled, then the antivenom infusion is given. Because the envenoming and the damage due to envenoming is greater if you do not complete the antivenom dose. So you need to continue it. And as I said, when you're giving a second dose of antivenom, then the reactions are less. That is our experience, because for the management of first reaction, we give steroids. So that will prevent reactions to second dose. Then will the steroid blunt the effects of antivenom? Won't. Actually, steroids won't blunt the effects of antivenom because this is the immediate one, right? It won't blunt. So this quadrivalent antivenom available in all hospitals in Sri Lanka, including very correct. Actually, antivenom is available everywhere, right? There are a lot of question came because of this financial situation in the country, whether antivenom is not available in the hospital. It's not true. Antivenom is available. Enough antivenom is available at the moment. And recently, we had a long discussion in our snakebite specialist committee regarding false newspaper articles saying that no antivenom available and patients develop all kinds of things. So many things were happening. So these adverse media things we were resisting, because public should have trust on the hospital management, then they should come. Otherwise, they go for all kinds of other remedies and end up with problems. What are the indications for antivenom? Are they manifestation of neurotoxicity, vascular toxicity? Yes, I said if the patient has hematotoxicity, neurotoxicity, nephrotoxicity, myotoxicity, cardiotoxicity, all are evidence of those are the effects of venom. If these effects of venom are there, then antivenom is indicated. Did the prepon create by Professor Line prescribed then? Will the patient develop AKI without coagulopathy on hump nose swiper? That's also an interesting question. Will the patient develop acute kidney injury without coagulopathy in hump nose swiper bite? Yes, it happens. Like in thrombotic microangiopathy, there are three things. The patient develop acute renal injury, then the thrombocytopenia, and the microangiopathic hemolytic anemia may or may not have coagulopathy, right? Patient can develop acute renal failure. Commonly, both are combined, but isolated it couldn't happen. What about the bosom crate? Right. This is an interesting question. Actually, what is called crate mimics. There are some benign snakes, they look like crate, right? So that is what identification of crate with correct morphology is necessary. There are a couple of crate mimics are there. They are benign snakes. So blossom crate is a different one. If symptom does not settle after 40 ampules, what is the next options, right? So 40 ampules means fairly big dose. So we have given probably 40 ampoules over 24 hours or 48 hours. And if the coagulopathy is persisting, that means patient is in VICC. So it's a bit of a tricky situation. Now there are trials where they have used fresh frozen plasma after antivenom, right? So there are debated evidence about their value, right? So if the coagulopathy is persisting, despite giving a large dose of antivenom, is really challenging. Depending on the particular patient, we have to decide what to do next, right? Right. So that's what the hotline is available. The expert can advise on it, right? You need to seek advice from the experts, right? Any place for give 10 ampoules to Russell's pipe in the first hand and should it 20. That's also interesting. I must tell you all, in 1990s or 80s, the antivenom available in Sri Lanka was Hafkine antivenom. That is a very good antivenom. Indian Hafkine company produced that. So that antivenom, 10 vials was the starting dose. That was quite adequate, 10 vials to start with, right? More than 70% of the patients used to get corrected the coagulopathy, the 10 vials. But later in this millennium, the 2000s and so on, we are importing antivenom from two different companies, Bharat and Vins. They are not that effective as Hafkine. So that is the reason the dose has been increased to 20. We recommend dose is 20. To prevent AKI, should we start early hydration? That's the point. I mean, prevent AKI, antivenom is the treatment, also the hydration, right? Other factor I should mention is this snake venom is an allergen. Sometimes after snake bite, patient develop low blood pressure and even the anaphylaxis due to venom itself, not due to venom toxicity, because of venom allergy. So during that time, the blood pressure is low, patient look dehydrated and so on. In that case, hydration is important from the very beginning. Under TMA, whether TTPO atypical HU is common with awake venom. What is that? I can't understand. Under TMA, whether TTPO, I couldn't understand, right? Can you give all mode of painkillers or IM without reluctant severe pain? No, I mean, in snake bite, we don't recommend IM injections because of the bleeding tendencies. The pain relief in snake bite is also important. In fact, recently in our committee meeting, we have been discussing about this pain relief in snake bite. Some measures can be done. For example, local application of local anesthetics, right? And the simple analgesics like paracetamol can be given to relieve the pain. Otherwise, not to give IM injections, right? Also not to give NSAIDs. Under TMA, whether TTP atypical HU is common with snake venom. TMA is actually not that common, right? It happens in thumb nose and rarely with Russell's. But now more and more cases are coming about the TMA due to a snake bite. And sometimes without full-blown TMA, they can have microangiopathic hemolytic anemia. TTP is not typically happening, right? Or atypical HU is not typically happening. It's the combination of everything TMA. Do you have do we need to have time gap between a standard vaccine and the antivenom treatments? I'm not understand what you mean by standard vaccines. I mean, if somebody has snake bite, if the antivenom is indicated, you have to give irrespective of the previous medications, vaccine, and so on, right? IM tetanus toxoid indicated. Not immediately. the important thing is to manage the patient's envenoming. And once the patient's envenoming is fully treated, we have time to give tetanus toxoid if you really think there's a risk of tetanus is there. Common treatment for VICC. I mean, commonly we see coagulopathy, but the coagulopathy extending further is the VICC. That again, the treatment is good antivenom, right? Good antivenom for the VICC. Actually, adrenaline as prophylaxis is pre-medication is subcutaneous, not IM. We should not give, I mean, for the students, I stress, no reason you give adrenaline IM to a normotensive person, you will end up with disaster because the blood pressure shoots up, patient gets tachycardia, patient gets severe headache. Because I have seen this is happening accidentally given adrenaline mistakenly as local anesthetic, right? So it's a very dangerous situation. Only subcutaneous adrenaline and given 0.25 just 5 minutes before you start in the antivenom, right? Just before starting antivenom even, it's okay. Maximum will be 5 minutes. So if there's coagulopathy, definitely IM. Thing is, if the patient has severe anaphylaxis, then the adrenaline is given IM. In that case, we are not bothered about the coagulopathy because anaphylaxis is more dangerous than the coagulopathy, right? You need to go IM. So I think I got bombarded with so many questions, right? Answered to the maximum, right? Hope the students are benefited, right? So once again, I thank Dr. Suranta Perra for actually giving this opportunity to share my knowledge and experience with these students and the young doctors. And it is the dream of our committee, specialist, the expert committee of snake bite, the umbrella organization in the committee of SLMA, to see deaths due to snake bite become zero. So that's the future dream. So we need to develop our local antivenom, right? So that I did not talk about the attempts how we are trying to develop antivenom locally for our snakes. So that's a different story. Okay, thank you very much once again. Hope that we can wind up the session.
Yes, thank you very much for that excellent lecture. And same time, I'd like to thank all the undergraduates, medical students who joined today's Saturday talk. And we hope to meet in another